Um, Good morning. I'm Dr. Dewan. I'm an assistant professor in the Division of Laryngology at Stanford. And so this morning we'll be having a few lectures on the laryngology review for the boards. This is the first of three. So we'll just begin here with a little bit of anatomy overview. The larynx is made of 9 cartilages. 3 of them are paired and 3 are unpaired. They're made of 2 different substances, fibroelastic and hyaline. The fibroelastic component include the epiglottis, the corniculate, which is a paired cartilage, the cuneiform, which is a paired cartilage. The hyaline include the thyroid, the cricoid, and the arytenoids, which are paired, and we'll go over more of those in detail. The arytenoids sit on the aspect of the larynx, and they attach superiorly to the cricoid cartilage, or to the superior aspect of the cricoid cartilage. There are 2 processes, the muscular process and the vocal process. The muscular process is a lateral prominence, and the vocal process is the anterior prominence. So when we look down during laryngoscopy or flexible laryngoscopy in the clinic, what we see is the vocal process. And then this is also the site of granuloma development. The arytenoids are pyramidal in shape, so when we look at them, it looks like a small triangle or a pyramid is sitting on top of the larynx, essentially. The corniculate are on top of the arytenoid, and the cuneiform cartilages are the anterior and lateral to the arytenoid. So those are the 2 components. Essentially, they sit atop on top and to the side of the arytenoids. It's important to remember that the cricoarytenoid joint is a synovial joint. This allows the arytenoid cartilages to translate in both an anterior posterior axis as well as a lateral to medial axis. So they rotate in a cranial caudal motion. Fibrosis or fixation of the cricoarytenoid joint is seen in rheumatoid arthritis as well as trauma. That can lead to vocal fold immobility and respiratory and phonatory impairment.
Here's what I found.
So moving along, the cricoid is an unpaired cartilage. It lies just below the thyroid cartilage and above the entrance to the trachea. It is the only complete ring of the laryngeal skeleton, and it encloses the subglottis. As many of you know, the subglottic stenosis can result from prolonged intubation or intubation with an endotracheal tube that is too large for the patient. Pressure on the subglottis from the endotracheal tube cuff causes microinfarctions, and the body responds to this localized tissue death in a hyperactive manner, generating scar tissue, resulting in stenosis. And we can see some examples of that here. So the larynx can be divided into 3 independent areas. The supraglottis, which is above the true vocal folds, includes the epiglottis, the false vocal folds, the aryepiglottic fold, and the arytenoids. The glottis is the true vocal folds in the area 1 centimeter below those vocal folds, and then the subglottis is the inferior edge of the glottis to the inferior border of the cricoid cartilage. Subglottic sites, they have different histology and development. It is a pseudostratified columnar epithelium that they have. This area extends from the suprahyoid epiglottis through the infrahyoid epiglottis, the aryepiglottic folds, the false vocal folds, and the arytenoids, and you can see that here. Next, we have the glottis. It extends from the apex of the ventricle through the vocal fold and the floor of the ventricle 1 centimeter inferior. Its epithelium is different than the supraglottis. This is a non-keratinizing stratified squamous epithelium. And then next we have the subglottis. The subglottis is the inferior border of the glottis to the inferior edge of the cricoid cartilage. This again is respiratory or pseudostratified columnar epithelium. Subglottic stenosis generally happens at the level of the 1st or 2nd tracheal ring, so it's not really in the subglottis, but rather right below that. So the transition zone is that transition between the respiratory epithelium and the non-keratinizing stratified epithelium. And this is the area where we see recurrent respiratory papillomas. We'll move on to the innervation of the larynx. So in the innervation of the larynx, the important nerves for the boards to know are the superior laryngeal nerve and the recurrent laryngeal nerve. The superior laryngeal nerve originates from the nodose ganglion. It branches off just after exiting the skull, so 4 centimeters above the carotid bifurcation. It is a nerve from the 4th pharyngeal arch. The external branch is responsible for motor innervation to the cricothyroid muscle, which controls voice pitch. So when we do a laryngeal exam, and we'll look at one of those later, when we ask the patient to demonstrate the highest note that they can say and the lowest note that they can say, or we ask them to demonstrate a glide like E, we're testing the external branch of the superior laryngeal nerve. The internal branch enters through the thyrohyoid membrane. This is the area that's involved in a combined laryngocele. So you have a laryngocele that is both internal and external. That laryngocele is being transmitted through that foramen that the internal branch travels through. The internal branch of the superior laryngeal nerve is sensory to the floor of the ventricle and above. So if the internal branch is inadvertently sacrificed, usually during thyroid surgery, these patients will have difficulty sensing liquid or solid, but generally liquid that enters the ventricle, so they can aspirate thin liquids. So next we move on to the recurrent laryngeal nerve, which is the one that we generally think of when we think about innervation of the larynx. On the left side, it travels under the aortic arch, and on the right side, under the subclavian artery. It is the nerve from the sixth pharyngeal arch. Generally, we think that in surgical approaches, in terms of the anterior approach to the cervical spine, thyroid surgery, it is the left side sided nerve that is generally at greater risk. The paraglottic space is between the muscle and the cartilage on the other side of the vocalis muscle, essentially. This is where a thyroplasty implant sits. This area is very important for a T3 squamous cell carcinoma of the vocal folds. Once it enters the paraglottic space, it gets upstaged. And we'll review that in a later lecture. The vocal fold layers, the epithelium, as I mentioned earlier, is a squamous non-keratinizing epithelium. There's then the superficial layer of the lamina propria and the immediate layer of the lamina propria, as well as the deep layer of the lamina propria. It is the lamina propria that allows for the propagation of the mucosal wave. Then deep to that, we have the vocalis muscle and then the thyroarytenoid muscle. In laryngeal surgery, we hydrodissect, so we elevate the superficial lamina propria slightly and remove the pathology and then replace that. So that's what microsurgery or phonosurgery is. In vocal fold scar or sulcus, the superficial lamina propria becomes attached to the layers beneath it. So in the surgical approach for vocal fold scar, we hydrodissect that area. So we inject a little bit of lidocaine and epinephrine in that area. We make an incision trying to elevate that up, and then we just put it back down, basically to break up the scar that has attached that superficial layer to those beneath it. The mucosal wave is essential for phonation. The epithelium and the SLP oscillate over the deeper layers. Stroboscopy, and we'll look at one of these in a few minutes, shows the SLP vibrating over the underlying jelly. So if we look at pictures 1 through 10 here, it shows us the mucosal wave essentially begins on the inferior surface of the vocal fold and propagates superiorly. It's like the pages of a book opening and then closing. Vocal fold adduction is the bringing together of the vocal folds or closing the vocal folds. It is important to remember, and I mentioned this a few slides ago, the only muscle that is not innervated by the recurrent laryngeal nerve is the cricothyroid. Vocal fold abduction or abduction is the opening, or when the vocal folds come apart. The only abductor is the posterior cricoarytenoid muscle, and this comes into play a little bit later when we start talking about pathologies. So the larynx has several functions: airway protection, cough, controlling ventilation, the ability to valsalva, phonation, and it also has chemoreceptors and baroreceptors. So for vocal fold phonation, or for sound production, we need vocal fold closures, so the ability to bring the cords together, pliability of the SLP or the superficial lamina propria, and then symmetry of vocal fold movement. But symmetry is not required, but having symmetry improves voice quality. So how do we assess the voice? Assessment of the voice is both subjective and objective. Subjective includes, we use a scale called the Gerba scale. grade, which is the overall quality, roughness or unevenness. If you think of driving down a bumpy road, how bumpy that road is, breathiness or air escape. So if it sounds like a whisper, that's very breathy. Asthenia or lack of power. So as we age, if you think of sort of the typical elderly voice, the example that I like to give is Bill Nye, the science guy. There's a lack of power associated with that. And then strain is the last one. So strain is hyperfunctional. I'm pushing really hard to get the sound to come out. It's very common, especially for women, to use something called glottal fry. There's also diplophonia, which is essentially when you hear two sounds. We have the patient say a sustained E, and we can hear two different pitches. And then phonatory breaks. And phonatory breaks are very common when we have a lot of strain, but also in spasmodic dysphonia. So the objective measures that we use are jitter, which is frequency, shimmer, which is loudness, variation in the amplitude, and so shimmer is measured in decibels. So the important numbers to know here that normal male pitch is between 100 and 200 hertz, and normal female pitch is 200 to 300 hertz. So the differential diagnosis for hoarseness. Hoarseness is essentially caused by impaired motion or mass, neurologic dysfunction, or is it functional? So that's sort of the pathway that we have to think through. If there is a mass, can we tell if it is malignant or benign? And then if it is benign, is it a discrete lesion? Is it like a cyst or a polyp? Or is it a larger sort of diffuse swelling like laryngitis or Rinke's edema? So the signs and symptoms of vocal fold immobility. It's a breathy voice, higher pitch, reduced maximum phonation time. So maximum phonation time is how long can the patient say E before running out of air or breath or sound, really. Normal, you or I, should be able to do this to 12 to 15 seconds. Less than 8 seconds is abnormal. Does the patient feel out of breath when they're speaking? Are they unable to finish a sentence? Do they have dysphagia? And are they coughing when they swallow liquids? Essentially, are they unable to protect their airway or keep their vocal folds closed when phonating? This is the primary reason that we address vocal fold immobility is this coughing with liquids or aspiration. This represents aspiration risk. We have to ask the patient, have you had pneumonia? Do you have fevers, chills? In many of these patients, they have a vocal fold abnormality for kind of following a big surgery like lung transplant, cardiothoracic surgery, anterior approach to the cervical spine. And so these are patients that we are concerned about the development of pneumonia. So the sooner we address their vocal fold immobility, the better. So I started to get into this a little bit, but the causes of vocal fold immobility, is this a problem with the recurrent laryngeal nerve? So is it neural in nature? Is it mechanical? Very early on, I mentioned fixation of the cricoarytenoid joint. Is it iatrogenic? Thyroid surgery is the most common iatrogenic cause. Is it neoplastic? Lung cancer is the most common neoplastic cause of vocal fold immobility. Idiopathic, most of these, I would say over 50% of them, we don't actually find the reason for the vocal fold immobility. Is it traumatic? Was the arytenoid dislocated during a intubation? And is it neoplastic in that there's squamous cell carcinoma invasion of the joint and it's a primary laryngeal cancer? The important thing to remember here is when you have a patient who presents with an idiopathic vocal fold paralysis or what you think is an idiopathic vocal fold paralysis, there's no known cause. We have to get imaging from the skull base to the thoracic inlet. So CT scan of the neck and chest is important to evaluate the course of the recurrent laryngeal nerve. In that, we will find many cases of lung cancer. Sometimes we will find cases of thyroid cancer, and sometimes we will find cases of laryngeal cancer. But that is the important workup for this. So, and we'll get more into the workup for vocal fold immobility. We start by doing a cranial nerve 2 through 12 exam, closely inspect the palatal elevation. So you're looking for a high cranial nerve 10 injury. We perform flexible laryngoscopy and stroboscopy, the CT or MRI of the skull base to the aortic arch, and then we do a swallowing study, a FEES or a modified barium swallow or an esophagram. So management of unilateral vocal fold immobility ranges from conservative to surgical. So conservative would be voice therapy or speech pathology. We want to rule out aspiration. For those patients who are not interested in any sort of invasive management and want conservative management, we have to make sure that they're not aspirating. And so your speech pathologist will often teach them measures to reduce aspiration. So we have them tuck their chin and turn their head towards the paralyzed side. What this does is obliterates the piriform sinus on that side and directs the bolus towards the side that's working or functioning. And this helps them to protect their airway. These measures are effective for a mild glottic gap like the one pictured here. The larger glottic gap, these will not be effective. So temporary management of unilateral vocal fold immobility. We medialize the vocal fold, and we do this through injection laryngoplasty or injecting material into the paraglottic space. This has quick results, it's inexpensive, minimal side effects, minimal discomfort. The downside to this is that all of these injection materials are temporary. There are many, many choices as to what to use for injection material, and then where to do the injection, and then how to do the approach. So we start with the injection setting. We can do this in the office or at the bedside in the awake patient, or we can do this in the operating room with the patient asleep. And I often leave that choice up to the patient. You know, if there's somebody who's okay with needles, they're not someone who gets too terribly uncomfortable, we can do it in the office. The advantage to that is that they get immediate results. If we do this in the operating room, the disadvantage is that I don't get auditory feedback because they're sleeping. And then secondly, that we have to wait for OR time to get this done. So there are a number of materials available. Sort of the holy grail in laryngology is figuring out what material is the best, and we're still sort of searching for that. The most common thing that we use is Prolarin gel, which is carboxymethylcellulose. It's essentially a plant product. It lasts roughly 3 months. The next thing that we use is Prolarin Plus. It's CAHA. It has calcium in it, so it's white. It lasts 6 months to a year. And then the other very common option is autologous fat. You may or may not have heard of Teflon. In, I would say, the early 90s, people used Teflon, and then it was discovered that it causes granulomas. This is so long ago that I actually have not even seen a granuloma. For a period of time, laryngologists were having to remove or attempt to remove granulomas that had developed after Teflon injection. But I think that's sort of more historic fact at this point. There are many ways to do a vocal fold injection, and this is getting into a little bit of detail that I think probably will not be on the boards, but is more laryngology detail. These injections can be done transorally, through the thyrohyoid membrane, through the thyroid cartilage, through the cricothyroid membrane, and then through direct laryngoscopy. And direct laryngoscopy is what we use in the operating room. So why do we inject? And I went over this a little bit. For the temporary correction of incompetence due to unilateral vocal fold paralysis or paresis, also for the permanent correction of mild to moderate glottic insufficiency and glottic insufficiency from soft tissue loss of the vocal fold. Aspiration, particularly with liquids, hoarseness, poor cough strength, so to maintain pulmonary toilet is very important, and generally for glottic incompetence. So I mentioned a few of these things. The injection setting, the pro to doing it in the office is that you get immediate voice feedback. It's quick. The con is that the patient's awake. It's a moving target. Oftentimes I tell these patients that really the biggest discomfort is a little bit of ear pain. It's the same reason that we get coughing when you clean the ears from Arnold's nerve. The pain gets transmitted. You're injecting into a closed space, so they can a lot of times feel that pressure in their ears, in the ear on the side of the injection. And this, depending on how you do your injections, it can require a second pair of hands. So the method that I use to do my injection, I need usually an assistant or a resident to hold the scope while I do the injection. In the operating room, the patient is asleep. It's done transorally through a direct laryngoscopy approach. The advantage is that it's a stationary target. The patient's not sleeping and it's pretty painless, or not moving because they're sleeping and it's pretty painless. The disadvantage is there's no immediate auditory feedback for the surgeon. It does require general anesthesia and requires operating room time. So for the patient who has a lot of comorbidities, for the lung cancer patient who's developed a vocal fold paralysis, the office injection is really a better way to go. I mentioned a little bit of this, the injection materials. This is from an article by O'Leary, this table. The materials for augmentation injection are typically described as temporary, permanent, or long-lasting, and sometimes the permanent injectable materials include autologous fat, calcium hydroxyapatite, or CAHA, which is Prolarin plus, polydimethylsiloxane, or PDS, which is a particulate silicone, and then historically the polytef paste, which is Teflon, but we don't use Teflon anymore. The temporary injection materials include gelatin or gel foam, Surgifoam. We've found that that's very temporary, so we don't use that very often. The collagen-based products, which are Symetra, Zyplast, Cosmoplast, Cosmoderm, hyaluronic acid, which is Restylane, and Hyalofform, and then carboxymethylcellulose, which is the most common one, or Prolarin voice gel. The materials vary in duration of integration, so basically how long they take to get absorbed or dissolved, and are thought to vary in their specific viscoelastic properties and biocompatibility. One of the newer things that one of the groups is working on, I think it's the group at at USC, is working on a silk-based product right now. So I alluded to this earlier. There are three major approaches. This can be done percutaneously. That's how we transorally, and then the microlaryngoscopy approach. The goal is the same, is to get this filler in that paraglottic space. Once you choose a percutaneous injection, then there are three different methods to approach the percutaneous injection. Injection laryngoplasty in daily practice appears to be the most common. We are consulted often postoperatively for patients who've undergone lung transplantation, esophagectomy, cardiothoracic surgery to inject an immobile vocal fold. In the immediate postoperative period, these patients are at risk for developing aspiration pneumonia secondary to dysphagia, as well as poor pulmonary toilet. They're unable to cough up the secretions. They're aspirating and they cannot generate a cough to expel what is continuously falling into their lungs. So there are three approaches here to this vocal fold injection: the transcutaneous approach through the cricothyroid membrane, which we call from below, which is my preferred method; through the cartilage, which is easier in younger women as their cartilage is not calcified again; and then what we call from above, or through the thyroid notch. I find this to be the most challenging approach. That's the thyrohyoid space approach. So this is the original article from the group at UCLA describing the transcutaneous approach for the Teflon injection. The first transcutaneous injection laryngoplasty was described by Dr. Paul Ward at UCLA in 1985, and this is an article from the Laryngoscope. They show here using a rigid telescope or the Hopkins rod attached to a video camera. They used an 18-gauge needle attached to a Louis syringe that's filled with Teflon, passed through the cricothyroid membrane, and the vocal fold was medialized with Teflon paste. And they demonstrate here the coronal section of the larynx, where the 18-gauge spinal needle enters the vocal fold from the inferior space. So things have changed a little bit. We no longer use an 18-gauge needle. We use a 27, and we're no longer using a rigid telescope. The Hopkins rod, we use a flexible scope, but the basic approach is the same. So this is the transcricothyroid approach. This is the most common approach that's used. So we'll kind of go figure by figure here. The cricoid and the cricothyroid membrane is palpated. It's easiest to use the lateral aspect of your finger. The index finger of the non-injecting hand is placed over the cricothyroid membrane at the level of the inferior aspect of the thyroid ala. And then the 27 gauge injection needle is inserted at the inferior border. So you can feel the inferior border of the thyroid cartilage as you pass it. You're approximately 5 millimeters lateral to the midline in a perpendicular direction to the thyroid ala. And it's advanced until the needle makes contact with the cartilage. The needle tip is then pushed inferiorly to guide the tip under the inferior border of the thyroid cartilage. It's important to use this tactile feedback as the needle is traveling under the thyroid border. This confirms that you will be guided into the paraglottic space. With the needle tip in this position, you make sure not to retract the needle and you inject the hand. You bend the needle slightly at a 30-degree angle, essentially at the hub, and it's done by pushing the syringe against the neck skin while the needle tip is pointed superiorly and laterally. At this point, the needle is slowly advanced 5 to 10 millimeters, aiming superiorly and laterally. And we watch on the video monitor, and you can see that in the lower right-hand corner here. We can see the injection going in, the cord straightening out, and the needle is manipulated gently while injecting a small amount, small aliquots at a time. You stop injecting, have the patient phonate, check the closure. The material is injected while visualizing for the adequate medialization of the vocal fold. So the advantage is that this patient is awake, and so you can hear their voice and ask for that auditory feedback. The key point here is that this is a submucosal injection, so we should never really see the needle enter the airway. We don't, for that reason, we don't have to anesthetize the airway, so we're not having the patient gargle any lidocaine. We're not nebulizing any lidocaine. It makes it quicker. But most importantly, afterwards, we want the material to sort of spread out in that paraglottic space, spread out evenly. So we ask the patient to phonate. When we do the approach, quote unquote, from above through the thyroid notch, then we are piercing the mucosa, and we don't want the patient to phonate afterwards because the material will come right back out the hole that we've made. So it's two different approaches, sort of two different methods of management immediate post-injection. So this is the transcartilaginous approach and a transthyrohyoid approach, essentially. So for this approach, the laryngeal landmarks are palpated just as in the other. The index finger is placed at the level of the cricothyroid membrane, and the needle is placed perpendicular to the thyroid cartilage, approximately 5 millimeters lateral to the midline again, and 2 to 3 millimeters above the inferior border this time, as the vocal fold level is usually halfway between the thyroid notch and the inferior border of the thyroid cartilage. If the landmarks are palpable, you sort of make a mental picture of the target for injection. And that guideline that the vocal folds are in the middle or halfway between the thyroid notch and the inferior border is important also for doing a thyroplasty. The needle is then placed at the vertical level, the midpoint between the superior vocal fold and the inferior thyroid cartilage border, and gentle pressure until the needle is bent slightly at the hub and points laterally towards the paraglottic space. The injection is then performed while watching on the video screen, essentially. So the thing to remember here is that you're going through cartilage, so you need a bigger needle. You essentially make the hole with the 18 gauge needle if the cartilage is calcified, and then you go back and pass the 27 through that hole that you've made. It's kind of like drilling a hole. The needle that comes in the ProLaren box that comes with the injection things is non-coring, so you have to get a different needle. That's not going to help you go through the cartilage. And then the last approach that we describe is the transthyrohyoid approach. And this has this very famous thing called the double bend. The needle gets bent twice, and this is what I was referring to earlier. In these photos, you can see the needle actually piercing. It goes through the petiole of the epiglottis and pierces the superior aspect of the vocal fold. So you've gone through the mucosa and essentially made a hole there. In this approach, we infiltrate the local anesthetic over the thyroid notch and the thyroid membrane area. We inject 4% lidocaine through the thyroid membrane into the airway. So we're essentially numbing up the airway. And then under direct visualization with the flexible laryngoscope, the syringe is filled with the injectable material attached to the needle. The needle is bent in this double bend manner. This was first described by Amin et al. And then modified by Franco et al. The neck is gently extended, so we have the patient look up so that we can more easily palpate their landmarks. The mark is made in the hollow of the thyroid notch, in the midline with a marking pen, 2 to 3 millimeters superior to the edge of the cartilage, and then 0.5 milliliter of 1% Lido is injected subcutaneously at that marked site. We also give them topical anesthesia with a transtracheal injection of 4 milliliters of 4% lidocaine. And you have the patient cough or do essentially the laryngeal gargle to spread this all out into the larynx and pharynx. You want to aspirate as soon as you put the needle in, you aspirate a little bit of air back to make sure you're in the airway. And then you use a 25 gauge, so a little bit bigger needle in this case, that is attached to the syringe, and it's bent at 45-degree angles at the hub and then 1 centimeter from the tip, so the double bend. The distal flexible nasolaryngoscope is then, it's used. So in this case, and they demonstrate this in the photos here, this can be done without an assistant. So if you scope with your non-dominant hand, you scope with your left hand, and you can inject with your right hand. I think it takes a special kind of surgeon to be able to do that. The needle goes in through the petiole of the epiglottis, as I mentioned, and you can get there by palpating the thyroid notch. And you aim down at a 45-degree angle as the needle enters the larynx, just inferior to the petiole of the epiglottis, and direct to the appropriate side, essentially, because you've entered in the midline. And like I mentioned, in this case, you are making a hole in the top of the vocal fold, and so we ask these patients actually not to phonate right after the injection. We ask them to wait a couple of hours before they start talking. And then lastly, we have the transoral approach. This can be done awake. It can also be done, well, the microdirect laryngoscopy approach is done in the operating room, but in the transoral approach, the patient's tongue is held with gauze with one hand, and we use a curved syringe to access the vocal fold with the other hand. And this is like doing rigid laryngoscopy, essentially. What is interesting here is that we show exactly where to put the injection in this inferior picture here. So these black dots, the injection is at the junction of the anterior 2/3 and posterior 1/3, and we want to go as lateral as possible, and this is how we get into that paraglottic space. This diagram is helpful also for performing the operating room injection. So this is a transnasal endoscopic approach. This is one other way to do this, using a channeled scope, essentially a bronchoscope. And this can be done in the office setting as well under topical anesthesia. The flexible telescope with a working channel is introduced transnasally to the level of the laryngopharynx. And then we use topical anesthesia, 4% lidocaine solution. This is actually a sclerotherapy needle that's passed through the working channel of the telescope and directed permucosally into the paraglottic space, lateral to the affected vocal fold for injection augmentation. The length of the tubing increases the resistance to the flow of material while injecting, and so this requires a fair amount of pressure and often another set of hands to do this because it's a little difficult to inject. The authors here recommend using Symetra, which is micronized human dermal tissue. And we over-inject a little bit, which is seen in that middle photo. And it, as the liquid, as the water is basically absorbed by the body, it corrects itself as that aqueous diluent gets absorbed. Okay, and then we have the microlaryngoscopy approach, which is something I'm sure most of you have seen. It's done under general anesthesia in a similar fashion to the transoral approach. The patient is intubated, the head of the bed is turned 90 degrees from the anesthesiologist, the larynx is exposed and suspended. We take a look with the rigid laryngoscopy, and then using an operating microscope to visualize the vocal folds, a 25 centimeter long needle with a 25 gauge malleable tip is directed through the rigid laryngoscope in a transoral approach, and the needle is aimed laterally to the vocal fold at the level of the vocal process, essentially. So I like to do actually injection in 2 locations. We'll do this junction of the anterior 2/3 and posterior 1/3. So we do that. And then also I'll put a little bit posterior where the vocal process is to get that posterior glottic chink to close too. You'll see, so these are the needles that come with the injection material. And the needle is marked, that black line. I believe it was Clark Rosen, who historically used several cadavers to measure the depth of the vocal fold. And so that black line actually tells you just how far to insert the needle to get into the paraglottic space and not go all the way through it. So what are the downsides of injection laryngoplasty? It's important to bear in mind that the vocal fold injection, while it's a good quick procedure, it has many limitations. It's generally considered feasible for a glottic gap that is up to 3 millimeters, after which the insufficiency becomes increasingly difficult to correct. In cases of a posterior glottic gap or a significantly foreshortened vocal fold like we see here, arytenoid adduction is also necessary to medialize the laryngoplasty, and we often get better results that way. One limitation is the ability to permanently correct for glottic incompetence. All the materials that we talked about get reabsorbed by the body, so this injection laryngoplasty is not a permanent fix. Autologous lipoinjection may be inconsistent, so that when we use fat for injection, it's not as reliable as some of the other materials because of the variability in how it's prepared. And then the calcium hydroxyapatite can last 1 to 2 years. The packaging insert says it lasts 6 months to a year. It averages probably 18 months. The disadvantage with that CAHA is that it's thicker, so its impact on the mucosal wave can be significant. So what are the potential complications here? Respiratory difficulty. You can narrow the airway too much. You're injecting something into the airway, so there can be a risk of aspiration. Hemorrhage, I generally do not do these in patients who have an INR greater than 4. That's kind of and I tend to be a little bit more brave than other people, but you can get a vocal fold hemorrhage, if you're just unlucky enough to hit a vessel when you're doing this, and then injury to the adjacent laryngeal structures. Misplacement of injection is something that we talk about a lot, and probably the reason that I tend to not use the CAHA in the office setting. I'll use it in the operating room. But if you inject the CAHA more superficially, and we see there's a picture of that here, into the subepithelial lamina propria space, it can impact propagation of the mucosal wave, and it actually makes patients more dysphonic. Women, because of the size of their larynx, because their larynx is smaller, are at greater risk for this. But the CAHA causes inflammation and stiffness there. So the best thing to do is to take the patient to the operating room, elevate a microflap, and go in and try and get it out. And oftentimes, because it's sort of integrated into the tissue at that point, we're really unsuccessful. We have to talk about it because it is a risk, the reaction to injection material, but I've never actually seen it. I think it's very common, or very uncommon, sorry. And there aren't really a whole lot of documented cases of that. So we've talked about injection. There's surgical approaches as well. So the type 1 thyroplasty, with a arytenoid adduction, and there's laryngeal reinnervation. So the key point to remember here is that we wait 6 months to 1 year after the initial diagnosis of vocal fold paralysis. So if this is a iatrogenic or post-surgical, they had a thyroidectomy and they have subsequent vocal fold paralysis, we wait up 6 months to a year after that initial thyroid surgery before we offer them something permanent like this. So type 1 thyroplasty is done in the operating room under conscious sedation. I tell patients it's like getting a colonoscopy because I need you to be awake enough to talk to me. It can be done with or without an arytenoid adduction. I tend to stage these. I'll do thyroplasty first, and if their voice does not improve, if I don't like their exam after the thyroplasty, then we come back later and do the adduction. The more you can leave the strap muscles intact, less postoperative dysphagia they have. That being said, you need to get good access to the larynx. Our implant choices are, again, there's lots of different ones. I tend to use Gore-Tex, which is that flexible material that ski jackets are made out of. We cut it into a ribbon. I use Gore-Tex for people who still have some vocal fold motion, but are insufficient. So presbylarynges, Parkinson's patients, that group. The silastic block, many laryngologists will carve their own silastic block for the patient based on the patient's degree of insufficiency. We, kind of size it for them. I use the silastic block for those patients who have a paralysis. They need something firm for the mobile vocal fold to hit up against. And then there's also a variety of pre-manufactured implants. Arytenoid adduction is placing a suture through the muscular process of the arytenoid. It rotates the arytenoid on the cricoarytenoid joint. The most common indication for this is the height mismatch between the vocal folds or a large posterior glottic gap. This, because we have to turn the larynx around and get to the back of the larynx, can be relatively uncomfortable. So I like patients to be asleep for this. We do not do this under MAC. I do this under general anesthesia. And then laryngeal reinnervation in combination with the arytenoid adduction and the injection laryngoplasty. It does not restore motion. What it does do is restore tone, but you have to wait for the reinnervation, so it can take up to 3 months for those results. We connect the ansa cervicalis to the recurrent laryngeal nerve. That's the most common way to do this. The other way to do it is a nerve muscle pedicle, so the ansa to strap muscle. Bilateral vocal fold mobility. So patients who have bilateral vocal fold mobility can present with shortness of breath, biphasic stridor. The most worrisome is when they have a good voice, which means their vocal folds are close together. They usually have minimal dysphagia. So the first and most important thing is to visualize the larynx and then get the scan from skull base to thoracic inlet. Try and look at the course of the nerve, the recurrent laryngeal nerve, from the skull base to the thoracic inlet, and figure out what the cause is. Did this patient have an esophageal, thyroid, or mediastinal surgery? Did this patient have a stroke? You have to think about processes that could be bilateral. So there are a couple of different treatment options. We don't mention it, we don't talk often about it, but you can do nothing if this patient is comfortable, if they are not in an emergent airway situation, they've had a bilateral paralysis for a long time, you don't necessarily have to do anything if their cords are fairly far apart. For the patient who has stridor, shortness of breath, who cannot lay flat, for those patients, the tracheostomy is the gold standard. That is the best airway. And it generally has minimal impact on swallowing. It's sort of a myth that the tracheostomy tube has a negative impact on swallowing, and we'll talk a little bit about that later. The other thing to offer patients is a chordotomy. So you cut through one of the true vocal folds horizontally, and you also remove part of the arytenoid. It essentially creates a keyhole aperture for breathing. So they're no longer breathing between a slit that's between their vocal cords. You've created a lateral aspect to that too. The more you remove of the arytenoid, the more dysphagia and dysphonia they're going to have after that. So that's important to keep in mind. I tell patients who get a chordotomy that they're going to have basically like a heavy whisper of a voice. It'll be loud enough that they can talk on the phone and they can order food at a drive-through, but it's still going to sound fairly breathy. Oftentimes what we can offer patients is the patient who's in acute distress will do a tracheostomy here and now in sort of an emergent fashion, and then come back later and do the chordotomy and decannulate them. Now, this is a multi-step process, but this is for the patient who really doesn't want a trach, needs it in the short term, and then we can address the rest of this with a chordotomy later. This is what the posterior chordotomy looks like. It's also called the keyhole procedure, where basically you're making a lateral incision with the laser and taking out a piece of the laryngeal mucosa. So once you make that incision in the vocal fold is like a rubber band that's suspended from the anterior commissure to the arytenoid. Once you make that incision, the vocal fold kind of snaps back, it shortens. And that's what we see here in that post-treatment image. Okay, so moving on to some lesions. The most important thing in benign vocal fold lesions is the terminology. Dr. Clark Rosen has written a lot about this topic and the different classifications and terminology here. So benign vocal fold lesions. The mid portion of the vocal fold is the most common place for a pseudocyst. That is the place of highest force of contact. Look at the vascularity, essentially. So in this case, you see all the vascularity is running north-south, is running vertically. There are very few, almost no horizontal or lateral tributaries. We do not treat asymptomatic lesions, only if the patient is symptomatic. Very rarely do we treat people who are professional voice users with surgery, because anytime you make an incision on the vocal fold, you're going to cause a generation of more scar, which will have permanent impact on the voice. So voice therapy first. If you're going to excise a benign vocal fold lesion, you want to try cold steel versus laser. The problem with laser is that it has heat spread. So the area that you're injuring when you remove something is larger. Cold steel with a microflap is generally the better way to go. Vocal process granuloma. This is a big one. If you see it, it's a benign posterior laryngeal lesion. It can be caused by reflux, vocal overuse, intubation. We're actually seeing a lot of this in COVID patients. The COVID patients who've been intubated for a long time, but also for some reason, we don't really know why COVID is causing a lot of granulation tissue formation within the airway. The biggest thing about treating these patients, control their reflux, send them to voice therapy. In a big vocal process granuloma like this, we want to inject it with steroids to try and shrink it. We can also ablate it with the laser. And then sort of the last resort is Botox, and Botox is going to do force voice rest. So basically you're Botoxing the adductor muscles, so you can't bring the vocal cords together. If you can't bring the vocal cords together, this area is no longer being repeatedly traumatized every time you speak. So that force voice rest, we've done that for a number of professional singers, and it basically gives that area some time to heal. The biggest thing to remember about these is they come back. It's very hard to get them to go away forever and ever. That being said, if it's an intubation granuloma, once you've taken the ET tube out, it's very unlikely intubation granuloma is going to come back. Every other kind of granuloma will come back. Papillomas. So relatively common and probably gets talked about on very many board exams. It's caused by HPV. This is by nature benign. However, there is a low risk of malignant transformation. They're grape-like lesions. They're soft. So in this photo that you see below here, you can intubate this patient. You can easily push past the papillomas with the endotracheal tube. That being said, we don't like to do that because we don't want to seed the lower airway. We don't want to push the disease into the lower airway, but if we have to, we can. The papillomas will grow on vocal folds, in the oral cavity, in the nasal cavity, nasopharynx, in the trachea, and the bronchi. So when you do an exam, you have to examine all of these areas looking. The earlier the onset, the worse the disease. So I'm sure this will get covered in the pediatric lecture as well, but pediatric RRP, those patients who've had dozens and dozens of surgeries, their disease is worse than people who have adult onset RRP. There are many ways to approach this. You can use cold steel to remove these. You can use a microdebrider for bulky disease. So this patient that's pictured here, I would use a microdebrider. You can also use the laser, the CO2 laser in the operating room, the KTP laser in the office. There are many, many adjunctive treatments that have been tried. The utility of these has not really been proven. We use cidofovir, sometimes interferon, acyclovir, ribavirin. Indole carbinol 3 is an oral medication. It's basically a dietary supplement. You can tell patients to get it on Amazon. Also tell them to eat cruciferous vegetables. The mumps vaccine, photodynamic therapy has not really been proven. What has been proven, we think we're just starting to see the data now, is the vaccination for HPV, we think that this is decreasing the incidence of disease. We're not seeing as many new cases as we did 20 years ago. Spasmodic dysphonia is we're sort of moving on from the lesions now. This is a focal dystonia of the larynx. It is the third most prevalent focal dystonia. It's 1 in 100,000. There are 3 types. Adductor, so we get spasms in the vocal folds when we bring them together. Abductor, spasm in the vocal fold when you bring the vocal folds apart. And then mixed. Adductor is much more common. The voice is worse with stress or on the phone, but the spasms, you don't hear them when people are crying, laughing, and singing. Also, drinking alcohol makes the spasms go away. Basically, it's prolonged vocal fold closure and reduced amplitude of vibration. They have limited pitch and volume control. It's very frustrating for patients because when they go to speak, they're not really sure what's going to come out. It's very variable. It's much more common in women in a 7-to-1 ratio. It's more common in patients of European descent. Runs in families. 11 to 31% of them will have a family member with any kind of dystonia, different dystonia. 64 of 93, so 2/3 will have family members with laryngeal dystonia specifically, and then 1/3 will have other dystonias. Those with family members with a dystonia have earlier onset age of symptoms. It's interesting, and there isn't a lot of literature about it, but we tend to see this in people who've used their voices a lot. We'll see it in people who were teachers, and then later on in life or after they've retired, they start to develop spasmodic dysphonia. We're not really sure why. So the adductor sounds like a strained and strangled speech. It's irregularly interrupted. It's effortful voice. It improves with alcohol or benzo use. Worse with the voiced consonants. Bilateral Botox injections to the thyroarytenoid muscle are sort of the gold standard of treatment. So we have sentences that we have these patients read for us to try and discern which kind of spasmodic dysphonia they have. So Albert eats eggs every Easter early in the AM. Has a lot of those voiced consonants in it, and then counting from 80 to 89. And then abductor has breathy voice breaks because as the vocal folds come apart is when they're spasming. Prolonged speech at vowels, reduced volume. They have difficulty with voice onset after voiceless letters. So F, sh, ch, k, p. So she sells seashells at the seashore. Getting that S to come out is difficult because it's a voiceless letter. So you won't hear much. You'll hear a lot of breathy voice. So treatment for abductor spasmodic dysphonia is unilateral injection of the PCA. We don't bilaterally inject the PCA because it will cause the vocal folds to be unable to open. And the patient will have airway distress. So unilateral injection to the PCA. That injection is difficult because the PCA is posterior. We have to go all the way through the airway, or we have to turn the larynx in the awake patient in the office. So that's a little bit more difficult injection than the adductor injection. Spasmodic dysphonia diagnosis requires a history, physical examination, and then this is where we work with our speech pathology colleagues. It's really a listening exercise. We do the flexible laryngoscopy to rule out muscle tension dysphonia. We examine during connected speech. So I'm sure you've all heard the rainbow paragraph. We have the patients read the rainbow paragraph. We have them read those spasmodic dysphonia sentences, and we look for hyperadduction. So this is something that will come up in many contexts in otolaryngology. Botox. Clostridium botulinum is the source. It is a spore-forming obligate anaerobic bacillus. It is gram-positive, and it produces a neuroexotoxin. It causes botulism. There are 4 species of Botox which produce 7 different botulinum neurotoxin serotypes. Botox serotype A is what is used for injection. So how does it work? There are 3 steps in the toxin-mediated paralysis. One is binding. Botox A binds irreversibly to the motor end plate. 2 is internalization. The toxin is internalized by endocytosis. After internalization, the Botox cleaves proteins required for the release of acetylcholine vesicles. So the fusion or docking proteins. And this is known as the snare protein. And then 3 is the inhibition of neurotransmitter release. The process is irreversible and ends in flaccid paralysis. That being said, Botox is temporary. While the process is irreversible at the cellular level, there's regeneration. So then we also briefly talk about surgical treatment of spasmodic dysphonia. There have been a number of people who've attempted surgical management. The denervation reinnervation surgery is where we selectively cut the recurrent laryngeal nerve and we reinnervate the larynx with the ansa cervicalis. These patients can be hoarse for up to 6 months. It's recommended for patients who are under the age of 65 because reinnervation can take such a long time. They will have mild dysphagia to liquids for 1 week postoperatively, and that's because we've denervated their adductor, their primary adductor group. So they're initially, after surgery, they have some difficulty with glottic incompetence. The other thing that's been suggested is the type 2 thyroplasty, in which you physically separate the vocal folds, and those patients develop an immediate ease of phonation. Okay, so we're moving along a little bit to the functional kinds of dysphonia. Muscle tension dysphonia is essentially using the false folds for phonation. These patients have severe compression. So if we look at the photo below here, we can't even see the vocal folds. This patient is phonating, but squeezing and using all these accessory muscles. There's severe AP compression here. We can't see the vocal folds at all. Treatment is something called unloading the larynx. We try and essentially get these muscles to relax. There are techniques to reduce the accessory pharyngeal contraction, and these are best employed by the speech language pathologist. Just as otologists need an audiologist to help them do their job, we as laryngologists need a speech pathologist to help us. Patients will have a better voice and a better exam once they figure out, we use biofeedback techniques to figure out how to relax these muscles. We'll move on now to discuss swallowing, one of the other functions of the larynx. There are 4 stages in swallowing: the oral preparatory phase, oral, pharyngeal, and then esophageal. In the oral preparatory phase, lip closure holds food in the mouth. The labial and buccal muscle tension is used to close the lateral sulci on either side of the tongue. There's jaw movement, and then the tongue movement begins to position the food against the teeth. The soft palate seals off the oral cavity from the nose. We use cranial nerves, the V3, 7, and 10 primarily for this phase. Then we move on to the oral stage. The tongue seals off against the teeth laterally, and the tongue propels the bolus posteriorly. The pharyngeal stage is triggered when the food enters the oropharynx. It's mediated by the glossopharyngeal nerve, and it is the most important phase of swallowing. We have velopharyngeal closure, prevents the food from going up into the nose. The tongue base moves posteriorly and propels the food bolus inferiorly, and then the pharyngeal contraction pushes the food inferiorly. Airway protection is done by laryngeal movement of the strap muscles anteriorly and superiorly, so hyolaryngeal elevation. Laryngeal closure is done by the epiglottis, the false folds, and the true folds. And then we have cryopharyngeal or upper esophageal sphincter opening. And then lastly, we have the esophageal phase. This begins after the upper esophageal sphincter relaxes. The esophagus, the upper 1/3 is mixed voluntary and involuntary. The lower 2/3 is involuntary. And this is the longest phase of the swallow. Dysphagia is any disruption of bolus transit from the oral cavity to the stomach. Complications of dysphagia include pneumonia, aspiration, malnutrition, dehydration, and weight loss. Causes are wide and varied: surgery, radiation, chemotherapy, age-related changes, and there are a number of systemic illnesses and neurologic conditions. The patient with dysphagia can have the subjective sensation of difficulty swallowing, but also objective abnormality in their swallow. They can present with a wide variety of things, ranging from cough to chronic halitosis, drooling. I have to swallow multiple times every time I take a bite. Chewed food comes back up. I feel like there's something stuck in my throat all the time. So penetration versus aspiration. Penetration occurs when content enters the laryngeal inlet, but is then expectorated. Aspiration is when content passes through the vocal folds and continues into the lower airways and is not coughed out. It's important to know the difference because you'll see both terms in an assessment of swallowing. Aspiration can occur during the oral and oral preparatory phases because the airway is open. It can occur in a delayed or absent pharyngeal swallow, so food rests in the vallecula, piriform, or laryngeal inlet. And then if the pharyngeal phase is not activated, the larynx won't close. It can result from reduced laryngeal elevation, reduced tongue-based contraction, reduced pharyngeal contraction, laryngeal injury, upper esophageal dysfunction, which is the most common, and then also age-related changes as well as deconditioning in the hospitalized patient. So how do we assess the swallow? There are a variety of tools, and we go essentially in this order. We start with laryngoscopy, stroboscopy, and fees. That's generally all done kind of at the same time in the clinic. And then we refer patients for a continued workup, either a modified barium swallow, an esophagram, or high-resolution manometry. So stroboscopy has generally been thought of as a tool for examining the voice. However, in a patient with dysphagia complaint, we're looking for vocal fold paresis or weakness, vocal fold paralysis, causing glottic incompetence, and then signs of pharyngeal weakness. So this is an example of a normal stroboscopy. Okay, so we see the vocal folds coming together. This patient has good glottic competence, good vocal fold approximation. So the next thing we do is a fiber optic endoscopic examination of swallowing safety, or FEES. This was first described in the late 80s by Susan Langmore. Indications for FEES include chronic cough, globus, necessity to swallow multiple times. Any patient you think has dysphagia, a patient who has a wet voice. The purpose is to detect aspiration and then to determine the safety of oral feeding in patients for whom traditional fluoroscopic feeding examination may not be possible. Its job is to dynamically assess the pharyngeal stage of swallowing. So these are the steps. The way I perform this: topical anesthetic to the nose, insertion of a flexible laryngoscope to the level of the soft palate. We observe the laryngeal mechanics, and this is why we start with the strobe exam. Look at the vocal folds moving, look at sort of how the larynx is moving. And then we test the swallow with 3 consistencies. We have patients applesauce because pureed is the easiest consistency to swallow. So we start with the easiest thing: applesauce, water, thin liquids are the most difficult, and then cookie, which represents a solid, and then a sip of water to wash the cookie down. And then we remove the scope. The whole thing takes about a minute. So what does the FEES show us? So when we do a FEES, we start with the front of the mouth. We're looking at dentition. So when I give the patient the solid, the cookie, I'm trying to see, do your dentures fit? How do your teeth function? Do you have any teeth? And then we're looking, can we form a cohesive bolus? Is there timely bolus transit? Does their soft palate close, or am I seeing nasal regurgitation? Is the base of tongue able to propel the bolus? Does the epiglottis evert with the swallow? And is there a whiteout? During the whiteout period is the actual swallow. And we can't see with the camera because the soft palate elevates, the tongue contacts the posterior pharyngeal wall, and then the bolus goes down. So really what we do is we analyze immediately after the swallow, where is the residue? Is the residue in the vallecula? Is it paralaryngeal? Is it in the esophageal inlet? Are there signs of penetration? Do we see residue on the vocal folds? And are there signs of aspiration? Can we look past the vocal folds and see if there's residue in the airway? So after we've done the FEES, the next thing we do is transnasal esophagoscopy. I routinely, as a laryngologist, perform transnasal esophagoscopy awake in the office setting. So patients who have a chronic cough, residual food in the pharynx after the fees, globus, foreign body sensation, history of food impaction, dysphagia or dynaphagia, unexplained weight loss, doctor, I can't swallow anything, having to spit out food, history of GERD, particularly people who've been on a PPI for a very long time and no one's ever looked in their esophagus. And then people who have a history of head and neck cancer, especially those who've gotten radiation. So the transnasal esophagoscope was first described probably about 15 years ago in a position statement from the ABEA, published in 2008, indicates that it's a safe, useful office-based procedure that can be performed with topical anesthesia. They go on to say that it is superior to traditional operative endoscopy in terms of safety, cost, and patient preference. The crux of all three being that it involves for the evaluation of the air digestive tract without sedation. The role of the T&E in the clinical otolaryngology practice is outlined, especially in terms of head and neck cancer. The authors report a very high congruence rate for biopsies using the T&E as compared to standard operating room pan endoscopy. The T&E plays an important role, as I said, in the diagnosis and management of patients with dysphagia, reflux disease, as well as head and neck malignancy. It has a working channel, so it allows us to do things like biopsy, laser, foreign body removal, dilations, as well as TEP, speech prosthesis placement in the total laryngectomy. So it's a big scope, and how do you do this without making the patients run away? So Polat et al. Published this study about 5 years ago, I think, indicating that the T&E is easy and well tolerated in the office. They looked at a cohort of 314 patients. In that group, 302 of them were able to undergo the T&E in the office. The average T&E time is less than 5 minutes. Those 7 patients who could not participate, 2 of them had epistaxis after the procedure, and there were no other complaints. It's not as big and scary as it looks. It's 60 centimeters long, has a 5.1 millimeter diameter and a 2 millimeter working channel. The important thing to remember about the esophagoscope is that it has an air pump, so you can insufflate, because as we remember, the esophagus is a flaccid organ. It's closed essentially all the time until food passes through it and opens it and causes peristalsis. So you use the air pump to insufflate. It also has a water pump, so you can give water, and it has a suction. So air, water, and suction, which is important. So when we do a transnasal esophagoscopy, what we look for, important landmarks, are external compression from the aorta, the left main stem bronchus, and the diaphragm at 24, 26, and 41 centimeters from the nose, respectively. There's a natural curvature at the base of the neck, slightly to the left. At the level of T7, we also slightly to the left, and then the diaphragm anteriorly to the left. So what I like to tell the residents when I'm teaching them this is that when you get to the stomach is at a 90-degree angle to the esophagus. So you have to rotate your hand when you try and enter the stomach. The gastroesophageal junction is very important. That's the Z line, or the transition between the 2 different kinds of epithelium, the squammal columnar junction. There's a serrated pattern that shows 4 to 6 small tongues toward the esophagus, sort of an undulating pattern. If they're any more frequent than 4 to 6 of them, if there is ulceration, if there is anything concerning here, then I refer the patients to GI for a formal biopsy. It is up to 5 millimeters long and 3 millimeters wide, essentially, the junction. And so we always, when we go through, we always want to comment on the Z line. The exam gets recorded, just like laryngeal exams, for immediate review. We review it with the patient, sharing with colleagues, and then long-term comparison of patients over time. So what can cause, well, just an example of a patient who needs a T&E. No one likes this patient. This is a 43-year-old female with chronic laryngitis. She's had no improvement with 3 months of PPI, and she also feels some gastric reflux and heartburn, right? So this is basically like dizziness of the throat. We started her on PPI. She doesn't get better. Now what do we do? Give her more PPI, add Zantac, which is now off the market, or review the reflux diet with her again. She needs an esophagoscopy because her chronic laryngitis could be caused by literally any of these things. So you've done a head and neck exam, you performed a stroboscopy and a fees, and then we're hoping to rule out any of these things. So the other test to consider after you've done the transnasal esophagoscopy is a modified barium swallow, esophagram, and high resolution manometry. We don't do all three, we kind of pick one or two, they complement each other. So by far the most common thing that I use is this modified barium swallow. It evaluates the swallowing function from the oral cavity to the mid-esophagus in a dynamic manner, but it's different data than we get with the fees and the T&E. In this issue of otolaryngology clinics, Brady and Donzelli describe the modified barium swallow as the gold standard for the evaluation of swallowing functions. They demonstrate that the modified barium swallow and the fees show good agreement with diagnostic findings as they are related to tracheal aspiration, laryngeal penetration, pharyngeal residue, diet intolerance, and compensatory swallow safety measures. So what happens during modified barium swallow? The MBSS allows for the identification of normal and abnormal anatomy and the physiology of the swallow as viewed by radiograph. It evaluates the integrity of airway protection before, during, and after the swallow. The modified barium swallow is used to evaluate the effectiveness of bolus modifications, postural changes, swallowing maneuvers to improve the swallowing safety and efficacy. So one of the things that I had mentioned earlier is when we have a unilateral vocal fold paralysis, it's helpful to have the patient turn their head toward the side of the paralysis and tuck their chin. In a modified barium swallow, we can have them do that and we can see on the radiograph what happens. What does that do to the bolus? Does that actually protect their airway? Is that particular mechanism helpful for the patient? We can do many things like this. And that's the advantage, is that the speech pathologist is performing this modified barium swallow in radiology with the patient, so they can sort of employ these techniques and see what works best. It involves the use of barium and fluoroscopy to assess the oral and pharyngeal phases of swallow. Patients are asked to eat and drink several different bolus consistencies and sizes. Each is coated or mixed with barium. The fluoroscopic images allow for the motion picture radiograph of dynamic swallow function. This is usually recorded and reviewed later on, reviewed with the patient and analyzed, and traditionally completed in the radiology department with a radiology tech and the speech pathologist. So we'll look at a couple of examples. So these are, the first one is normal. This is normal light tongue-based coating. So this is the oral pharynx here. We see a normal tongue-based coating. This is the airway here, and the esophagus is behind the airway, and then this is the spine. So this is a nice normal modified barium swallow. Here we see stasis in the vallecula and piriform sinus. This is a cricopharyngeal bar right here. We can see that narrowing, and then above that there's stasis on top, and then the stasis is actually causing backflow into the airway. So this is aspiration here. This is the airway, and then aspiration of the barium here. This is an obstructive epiglottis. So this epiglottis doesn't invert when the patient swallows, and so we get stasis above the level of the epiglottis. So this is an esophagram. In an esophagram, a cup of barium is swallowed and followed fluoroscopically to the stomach. It's not dynamic, it's done on plain film. It's helpful if there's a suspicion of a structural disorder. The pro is that it's widely available. The con is that we can't do this on bedridden patients. It doesn't show, and it doesn't show dynamic function. It's a single film that demonstrates the structure of the epiglottis, or the esophagus, sorry. The biggest advantage is that it doesn't require a speech pathologist. And then lastly is high resolution esophageal manometry. This is something that's done by our colleagues in GI. I will often refer patients for this. It is the gold standard in the evaluation of non-obstructive dysphagia. And it's Catheters with pressure sensors are placed 1 to 2 centimeters apart along the distance from the hypopharynx to the stomach. So the pressures along the entire length are measured simultaneously, and then software processes this data and produces what we see here, which is an esophageal pressure topography plot that represents the esophageal motility and sphincter function in a color-coded pressure space-time plot. Objective metrics have been developed for the analysis of this plot. So when we do the exam in the office, if we've done a FEES and then we do the transnasal esophagoscopy, it takes a few minutes to go from doing a FEES to transnasal esophagoscopy. We set up the scope, kind of change the room over a little bit. If there is residual food left in the esophagus, I've just fed this patient with a FEES and then I go look probably about 5 minutes later in their esophagus. If there's residual food left in there, that's an indication that they have an esophageal dysmotility, because everything should be gone from the esophagus in a minute. When I look with the esophagus scope, if the lower esophageal sphincter is wide open, if I don't have to sort of work a little bit to get into the stomach, that's an indication that they may be having some reflux because the LES is not appropriately closed. So that's an indication for high resolution manometry. Patients who can point to their mid-chest complaining of pain, pain with swallowing, chest pain with swallowing, that can be indicative of achalasia or esophageal spasm. That was something that we would also see on manometry. And then patients who have systemic infiltrative disease like scleroderma that can impact muscle contraction of the esophagus. So we'll go over a few causes of oropharyngeal dysphagia. There are many causes. These are just the big categories that I encounter daily. Chemoradiation-induced dysphagia, the long-term effects of radiation. Unfortunately, radiation is just the gift that keeps on giving. These patients can develop a cricopharyngeal bar or cricopharyngeal achalasia. Basically, the top of the esophagus, the UES, does not open as it should. Develop esophageal strictures and can also have epiglottic dysfunction. Cricopharyngeal achalasia is when the UES fails to relax. It can be idiopathic after a stroke, seen in vagal nerve palsy, Parkinson's, polio, dermatomyositis, ALS. The causes are wide and varied, but it's most commonly seen after radiation for the head and neck. This is not the same as delayed opening of the cricopharyngeus. Delayed opening is a swallow therapy problem. That is a timing issue. This is the aperture of the UES or cricopharyngeus not opening wide enough. Cricopharyngeal achalasia treatment is generally endoscopic. There are a few different things and a couple of review articles that have come out lately to find out kind of what the best treatment is. But this is an endoscopic cricopharyngeal myotomy. We use the CO2 laser. So in A here, the asterisk is marking the cricopharyngeal bar. And then in B, we have cut that bar using the CO2 laser. Glottic insufficiency with aspiration risk and dysphagia. We've talked a little bit about that a few slides ago. And then Zenker's diverticulum. Zenker's is a pseudodiverticulum that's very important to know. It involves 2 layers of the esophagus. The symptoms include dysphagia, regurgitation, aspiration, halitosis, bad breath, essentially because the food is starting to decompose in this pouch and hasn't made it to the stomach. It is a dehiscence in Killian's triangle. It's important to know what muscles make up Killian's triangle. And it is a result of increased cricopharyngeal tone. So a large area of Killian's dehiscence and increased cricopharyngeal tone play a role in this development. The common symptoms we've gone over. On exam, the most telltale sign is the presence of EPR or esophagopharyngeal reflux after a FEES. And we'll look at a video of that. Treatment of this problem is surgical. While we are all familiar with the open approaches to Zenker's diverticulum, the endoscopic management with the CO2 laser is sort of the latest in development of these approaches. And that was originally described in 2001 by Crespi et al. Group in New York. So the Zenker's diverticulum forms here. The sac is thought to be formed by a discoordination between the contracting pharyngeal constrictors and the cricopharyngeus muscle. Patients with Zenker's diverticulum are generally over the age of 60 years old and report gradual onset of dysphagia over a long duration. They feel like food sticks at the level of the suprasternal notch, and they'll often complain of regurgitation of undigested food from the pouch, undissolved pills as pathognomonic, foul odor, and taste. This is the original article describing how to surgically address this. We use a diverticuloscope. One tine goes above the party wall, essentially, in the esophagus. The other goes in the pouch below the party wall. So the tines straddle the party wall, and we make a perpendicular incision using the CO2 laser through the party wall. The open procedures for Zenker's diverticulum include diverticulopexy and diverticulectomy. Diverticulopexy basically means that you are pinning the sac superiorly so things can't get stuck in it. And that is also associated with a cricopharyngeal myotomy. Infection risk is low because you're not actually making you're not taking out the pouch, so you're not violating the mucosa. But in that case, the recurrence rate is also higher. In diverticulectomy, you do an esophagoscopy first, transorally, pack the pouch, then we open the neck, identify the pouch, and you perform the cricopharyngeal myotomy. And then you resect the pouch, but we have to be careful when we close it because we don't want to get a leak into the neck, essentially. So this has been done with a stapler, and then we invert the mucosal suture over the stapler, over the staple line. There's a significant risk of infection as well as risk of recurrent laryngeal nerve injury. So open diverticulectomy is really only done if for some reason the endoscopic case cannot be done. If the patient is too kyphotic, they cannot open their mouth wide enough for a transoral surgery. That being said, there is lately the development of a flexible transoral approach to Zenker's diverticulum, and that's primarily done by GI, and that may completely obviate the need for the open surgery. We'll move on to strictures and Schatzki's rings and webs. Patients will complain of dysphagia, heartburn, and reflux that doesn't respond to therapy. They have repeated food impactions. There are approximately 1 million causes, but it's important to know that pill-induced esophageal injury can cause rings, radiation exposure. This can be an anastomotic stricture in somebody who's had an esophagectomy or a total laryngectomy. We can have congenital rings. Treatment is generally dilation. Usually I like to do the first one in the operating room so we can get the best dilation. We inject a little bit of Kenalog in there to try and decrease the rate of return, and then we can subsequently dilate in the office. This is the original article that described how to do transnasal balloon dilation of the esophagus in the office. And we can see here that Dr. Rees is demonstrating there's a balloon and then there's the esophageal stricture. And the advantage when we do this in the office, the patient is awake, but we have a flexible scope in the nose, and so we can see the larynx. We can see if we're compressing the airway, and the patient can tell us if they're having difficulty. If you have found anything that I've said here interesting, my particular area of expertise is dysphagia in the head and neck. If the larynx is now your favorite part of the body, go ahead, you can look for my book. And then this lovely cartoon here. Basically, the trachea doesn't like water as much as our friend the esophagus. So that is the first laryngeal lecture. We can move on to some cases.